Hello, welcome to another podcast about eye care and eyewear. Today I am joined by Dr. Rahul Jain, who is a dedicated myopia management practitioner and also a cataract surgeon and a glaucoma consultant. He runs Dr. Jain's eye clinic in Bangalore along with his wife, Dr. Dhwani, who is a retinal consultant as well. So allow us and join us in welcoming Dr. Rahul to this podcast. So thank you, Dr. Rahul, for taking out time from your busy practice and giving us time for this podcast.
Thank you so much. Pleasure being here.
And as you see, I have 2 pages full of questions to ask you.
That's so much pleasure for me to answer as well.
So we'll start off, right?
Sure. Yes.
So we keep on hearing this term myopia a lot nowadays. So what is myopia actually?
So see, basically, myopia is a condition where the child, especially, cannot see far off things. Like we restrict our thinking that only far off things are not clear. But imagine a child who has -8 number. He cannot even see something that's on this table. So basically, though we call it a short sight, means the person can see something that is near. It's actually very difficult to imagine that even the table will not be clear for that child. So it's a disease where you can't see far off things, even as close as the table. The child has to literally hold a book so close to his eye if he's -8. So that is myopia.
So if I have understood it correctly, that if a child has a myopia, the child can see the near, probably pretty close to the face,
very close to the
but
face.
can't see the far off objects at all.
Yes.
And like we have heard a lot that this myopia is increasing every year on year.
Correct.
So why do you think it is increasing?
So what I tell parents who come with children, there are 2 most important things these days. One, lack of outdoor activities, and more near work. These are the 2 most important things because of which the myopia is increasing.
So you said lack of outdoor activities and more of near work.
Near work,
right?
Near work. Yes.
So like how much should a kid spend outdoors as per you?
So as much as possible. There is no minimum about it. I generally tell kids to spend at least 15 hours a week. At least, that is at least. But more than that is also good. It's not just for the eyes, but let's think a childhood. If they have played outside, their bones are also stronger. So you always hear from the orthopedic doctors, play, jump around. So it's just not for the eyes. Let's not just focus on myopia, but it is also about the well-being of the child. So the more time you spend outdoors, the better it is. There is no minimum limit for it. 2 hours a day is like the least minimum that I ask my children to spend time outdoors.
So have to be 2 hours.
Have to be 2 hours.
Have to be 2 hours.
I know everybody is busy studying, but I think so Saturday, Sunday, weekends are like, and even holidays, summer holidays, they can really take out time. And very interesting fact, if you don't know, that it increases more in winters. Myopia is faster in winters compared to summers.
Okay. Because of the sunlight?
Sunlight, and they tend to be more indoors because it's winters. It's more cold, lack of sunlight. Bangalore as such has less sunlight. So I see a lot of kids progressing faster in winters than the summers.
So summer or winter, we have to be outdoors.
Outdoors, yes.
At least 2 hours per day.
Yes.
So 14 hours in a week, at least. That's the minimum time we should spend outdoors.
Yeah.
That's very insightful. And then you said also use of near work, right?
Yes.
So is there a limitation of near work per day for kids?
Yes, there is. Like we say, it's the foundation laid are for screen time basically. So we tell children not to spend more than 2 hours on screen. Less than 2 years children, absolutely no, because they are the kids who generally develop autism later in life, because there's so much involved in screens that they don't hear what is happening around. So the learning capabilities of those child actually goes down. So that's another reason why autism or ADHD is increasing, because they are exposed too early to the screen early in life. But after that, at least after 4-5 years of age, I tell not to spend more than 2 hours, including the studies, like if they have something on the screen to do. And also I tell them, if you are spending more times on screen which is related to study, please mirror it on a TV, sit far, connect your iPads, phones to the TV, so that you increase the distance. That's like a very good thing that you can do if you have to compulsory spend that much time.
So what I learned from you is lesser than 2 years, no digital device at all.
Absolutely no.
Not even when they're not eating.
No,
Right.
no, absolutely no. No
Okay.
Peppa Pig.
No paper bag. The
Yeah.
second thing I learn is farther away it is better for them,
Better, yes.
right? And they should not work for more than 2 hours on a digital device,
Yes.
including everything that's
Yes.
recreational and everything that is
Yes,
educational,
including video calls.
including video
everything.
calls.
Yeah. Yes.
You spoke about ADHD and you also spoke about autism. That can happen if we are using digital devices at an early age, right?
Correct.
So is it a reason that we normally see ADHD or autism patients understanding patterns much better than humans is because of the digital device exposure?
Maybe I'm not the expert in that, but I think so. Yes, it may be the reason. Yes.
So it's not just the eye problem, but also these behavioral problems that
Yes.
can be stopped if we
If we reduce the screen
reduce
time.
the screen time
Yes,
for them.
definitely yes.
And tell me one thing, we are now all worried about this term myopia, right? Everywhere we say,
Correct,
slow down
correct,
progression of myopia,
correct,
slow down progression of
correct.
myopia. Your kid should not become myopic at all.
Correct.
Why are we worried about it? Like it's a eye power. I wear my glasses and
Yes.
I can see clearly.
Yes.
But why are you worried about this myopia?
That's a very good question. So I will explain. See, it's not a condition. Say 10, 20 years ago when we were myopic, our doctors, eye doctors, you say, just wear a glass. That's it. That's all you have to do. But it leaves behind a disease. Suppose I get a LASIK done for myself at the age of 25. I am relieved of a -7 number. But the disease that myopia leaves behind in your eye is something that is more important. So what happens if the child becomes myopic? These are the children who will develop more chances of retina problems later in life. Even glaucoma, even cataract, maculopathy. These are very serious eye conditions that generally needs more attention at this stage. The longer the eyeball, basically myopia is all about longer eyeballs. So the longer the eyeball, the more the disease in these children.
So it's not just a vision problem, but it will have a lot of sight-threatening issues at the later stages
Yes,
of life
absolutely. A lot of them, yes. Higher the number, again, in myopia, higher the number, the more the chances of retina problems. So let's take an example, say somebody is -3. -3 to -6 children are 9 times more likely to have retina problems, and more than -6, what we generally call pathologic myopia, where the eyeball is longer than 26 millimeter. They are at 20 times higher risk of developing retina problems.
as well. Got it. So, at the later stages of my life, I will have an issue if I get myopia now, right?
Yeah, generally myopia is not something that develops at this stage. At younger age, it grows faster, it progresses faster. Yeah.
So, what is the youngest kid you have seen having a myopia in their eyes?
I think so, 2.5 years.
Oh,
That is the earliest I can make the child sit on a slit lamp or a AR. Otherwise, I think so, maybe some kids develop even earlier because of the screen time.
Because I asked you this question because many a times parents think that there cannot be no problem because it's a kid. Their eyes will be perfectly healthy,
Correct.
like the other parts of their body.
Correct.
So you are getting myopia as lesser as 2 years as well,
Yes.
right?
I think so. The other reason is a lot of parents in bigger cities leave their kids for daycare. And in daycare, we don't see bigger rooms. A lot of daycares have darker rooms, smaller rooms. There's no sunlight over there. And the kid continues to be in daycare at least till he goes to first standard. So generally parents shift the kids from UKG to first standard in a bigger school. And that is the prime time when they have to get exposed to sun. So that is another reason why myopia is more likely in urban children who are in put in kindergarten schools which are smaller, or rooms which are smaller and less exposed to sun.
So you said sunlight is very, very important
Yes, it
as
is
well, right?
the most important thing. Yeah.
So that's also around 15 hours. They should be under the sun.
Yes.
Right?
I see, if the kid is going out, I don't tell them to just go out. They can wear a hat, they can wear a goggle to get protection. And not necessary that they have to jump around in the garden or play area. But even activities like if you want to play Ludo, you want to play snakes and ladders, or say it is raining, you just don't want to go out, then just sit in the garden and have fun there. That's good enough. Yeah. So any activity that can be done outside should be done outside. Yeah. We have a very good apartment where we stay, and we have made a rule to all children nannies that they should get lunch as soon as they come from school and have it outside in the garden. So that way, what happens? They are not indoors, they are outdoors, and they don't see TV because there is no TV in the garden, and they enjoy being outdoors. So there are these some cultural changes that we can incorporate in bigger areas like apartments or societies where uh, the myopia problem can be tackled in a very simple way.
So, my take home tips from this particular answer of yours is take the kids outside,
Yes,
make them sit under the sun and
yes,
eat their lunch. That
yes,
way, they can avoid television and get the
yes,
sun exposure as well.
yes, yes,
And
definitely.
probably we will be able to get that 15 hours of sun exposure
You can definitely
every
get,
week.
yeah. Let's take Saturday, Sunday. Most of the kids have holidays, and we are talking about kids who are at more risk. So the kids who are at more risk are, say, till 12 years of age at the highest risk. So at least those children are not so very involved in studies. They don't need to be very aggressive about academics and compromising the health. So I would advise all children who are on the lower grades, like first, second, third, fourth, to be more outdoors on weekends at least. I can still understand they may have a lot of homework to do even at fourth standard, but Saturday and Sunday is definitely possible.
That's very insightful. And you are seeing kids and parents day in and day out. As per you, how aware are they? Like, how aware are parents like us on these things about going out, spending time under the sun? How aware are they?
I think so. They only feel that screen time is most important factor for child developing glasses. But that's not only the thing. A lot of parents don't know that sunlight is equally important.
So that's good. And I'm very sure most of the parents like ourselves don't know when to take a kid for an eye test, because most of the time we
Correct.
feel that the kid should complain,
Correct.
and then we can
Correct.
take
Correct.
them to a doctor like you.
Correct.
So what is the right age to get a kid's eyes tested?
If the kid is able to read ABCD, that's the easiest way the doctor also can pick up. So let's take a kid who is like 3.5, 4 years. On an average, these kids will cooperate. Even if they can identify some charts, some pictures, that's also a good age. So I would say 4 years, 4.5 years is the minimum like age where the child should come and get an eye checkup done.
Even if they're not complaining of anything?
No, yes, definitely. And thanks to schools, a lot of schools have started this, the compulsory eye checkup before even entering the class. So that's even a good thing. Like they do end up coming to us then, because we have to sign in the diary. Yes.
So as early as possible?
As early as possible, around 3.5, 4 years, I would say. Yes.
And a grown-up like us, how often should we get our eye tested?
If you have no issues, you don't have a number, you don't wear glasses, say once in 3-4 years at this age, and then once you cross 40, once in 2 years or so is a good thing to get your eye checkup done. Yeah,
that's insightful.
Yes.
Now we saw that you have a specialty myopia clinic,
Yes,
right?
yes.
So why did you start it even?
That's a very interesting question. See, I would start a little with population in India. We all know, let's forget about statistics, like what is the world's population, how many people are getting myopic. Let's forget about that. You ask any doctor in India, are you seeing kids these days more with myopia? Everybody would answer yes. So let's take it that way, that every doctor who is sitting and practicing general ophthalmology has a lot of kids who have myopia. So just by seeing more kids in OPD, we know that the number is increasing. And especially where I practice, there are a lot of kids who have myopia. And that is one reason. And India has about 35 to 40 crore children who are under the age of 14. So 1/6 of world's population, say around 220 crores population of the world is under 14. And 1/6 is in India. And I think so a lot of them are around me. So that's the most important factor. But apart from that, I love seeing kids. I have a lot of passion to see kids. I have that patience that it needs to tackle these children. So that was the main reason why I started my clinic.
That answer make me ask you another question.
Yes, sir.
How difficult it is to see a kid? I know how difficult it is to parent a kid, being a parent myself.
Yes,
but as a practitioner, how difficult it is to see a kid?
So you need to have chocolates, stickers in your OPD. So that way you make it easier. But when a kid comes to me, I assess if the kid is going to be a little difficult kid. We don't put drops the first time. We just make the kid comfortable, we send them with a chocolate. Just put a torchlight. If the kid can sit on a AR machine, just to get a rough idea of what the kid is having. Say if the kid has a problem, then I talk to parents and ask the kid to come back within 2-3 months. Make the kid understand that they have to read something in the OPD or identify charts. And because we end up giving chocolate stickers, they are more motivated to come. And so you can do simple things like if you want to do a refraction to the kid with the drops, you can actually send the drops with the parents and ask them to put it at home and come. So there are small things that we can do and get these kids who require a full checkup a little early. And those who are reading well and who are able to sit on a AR machine, and we know that it's not a myopia or not a kid who is going to develop myopia, we can be a little less aggressive. Yeah, so there is a lot of effort. It's just not the myopia clinic, but the entire staff has to be very friendly with these kids. Like anything beyond 7-8 years, the kids are generally cooperative. But these earlier the kids, and earlier we catch them, it's more comfortable for us to treat. The more we can save.
So I witnessed a lot of friendly staffs, sure, in your clinic. That's
all
for
are
sure.
young people.
Yes, and all smiling.
Yeah, all smiling. Yes.
So the other thing is, as a parent, how much time shall I take out of my schedule for my kid's eye test? Like, can it happen in 15 minutes, 20 minutes, or shall I take out an hour, 2 hour? What is your suggestion?
So I think so. If they come to OPD, at least an hour is definitely necessary. But I would still advise parents to not keep anything else important on that day, because if we need to do a little more checkup and talk to them, make them understand. See, the parent always comes with the hope that the child is fine. And if the child is not fine, if the child has a problem, then it takes a little time for them also to first accept it and for us to explain what has to be done. So we can always schedule a next appointment according to the parents' schedule. But the first time when they go, let them take out a little time, say roughly 1 hour, 1 to 2 hours.
1 to 2 hours. So no hurries.
No hurries, yeah. The doctor needs time because these children take time. Some children do well after half an hour when they come. They play a little. They get used to the whole clinic environment.
That's insightful. So can you tell me in details, like what as a parent can I expect when I bring my kid to your myopia clinic? What happens? What is the process? You said that okay, first day we'll see her eyes and everything,
Right.
and we will also make her feel comfortable as well, right? And then what happens?
Yeah. So when you get your kid, we first get them inside my room, and we do a simple AR. AR is a machine where we can get to roughly know what the kid's power is. AR may sometimes show very wrong readings. That depends on how the child behaves. But if the child is able to read till the last line or till the line that he's supposed to read at that age, then we also put drop, and we don't put cyclopen to every kid. I personally feel it's not required. We just put a T plus and we dilate the child. We see the retina, and if I feel that the child requires any further test, if there is a problem with the child, then we definitely do something known as topography. So topography is a machine which detects what is the curvature of the cornea. Cornea is the black part of the eye. So we do that, and after that we also do axial length of the eye. Axial length is the total length from the cornea to the retina. So these two are the most important tests that are needed for a child myopia progression analysis, or to even detect what the child right now is at risk, what kind of risk the child has.
Oh, okay. So there will be a lot of tests that will happen into the kid's eyes, and you will be able to see from the front of the eye till the back of the eye,
Till the back of the
and then do a diagnosis
Yes.
and probably give a suitable treatment for the kid if the kid requires.
So many times I would like to add one point. Suppose the kid actually reads 6 last line, but sometimes if the kid have flatter cornea is, again, as I said, the black part of the eye. If they have a flatter cornea, they are the kids who will still have a longer eyeball, and we are missing them. So it is very important to do topography also. So with that, if I see a child with say 40 diopters of flatter cornea, I really want to do that kid axial length and check whether he is already having a longer eyeball. So it's not necessary that the child has 0 number and he's fine. He or she is fine. Even if they have a 0 number, they may still have a longer eyeball. And as I said, myopia is all about saving the length of the eyeball. Numbers are not important. Truly, the numbers are not important. The power is not important.
So, and that's normal refraction will not reveal the problem at the
It
back.
will not reveal. A lot of kids are missed in this process. When we see a kid, the kid is reading 6 by 6, AR shows 0 or plus 0.75. According to the kid's age, we miss a lot of kids in that. A lot of kids who have only cylindrical powers, there is a misconception, this is also a thing, that myopia glasses are only for kids who have spherical number. I have a lot of kids who have only minus cylinder number, but their actual lens are longer. A lot of times I get a call from the lab also, sir आपने check की कर लो, आप एक बार check कर लो, because it's only a cylinder number, why have you given a myopia glass? But these kids have flatter corneas, and they are the ones who have longer eyeballs or going to have a longer eyeball, and that's why we want to start myopia treatment as early as possible.
So listen to the practitioner and trust his judgment,
yes,
right?
yes,
And not put our heads into it.
yes, yes, definitely.
That brings me to my next question.
Yes.
I learned that how do you manage kids? Now the question is how do you manage parents?
Parents, yes. So the key is lesser you tell about it, the better it is. You don't have to scare. Like sometimes what happens, practitioner knows only limited. So he or she wants to tell everything that he or she knows about it. So that's not how it is. You don't have to tell the parent anything. You don't have to scare them. That's the whole point. Like you want that parent to come back to you. So you just have to tell that your kid has a certain condition and we need to keep checking that. And if they ask, only then I answer, why are we doing this? What is the reason that we are doing this? Then I tell them that if we save the length of the eyeball, they are likely to have less number of eye problems later in life. You don't have to use words like retinal detachment, glaucoma, cataract, maculopathy. They don't want to know these things. They don't want to get scared also. You just have to be very patient. Tell only what is required to tell. Too much information is not good for parents also. We are not here to scare them. That's why I did not speak about statistics, like half the world's population is going to become myopic. So that's not important. What is important is what we have today in front of us and how we can tackle that.
So you're saying that if we follow all the advices that our practitioners like yourself are giving us, we don't have to even worry. And there is nothing to be scared
Yes,
of
there's
because
nothing
things
to
will
be.
be taken care of.
Correct.
That's interesting.
Again, an important point. Every kid who has high number is not going to develop a problem. That is very important to understand. Everyone who has -6 is not going to have retinal detachment. So there is no need to worry about things. And those kids whom we catch early are anyways going to be at less risk because we are going to treat them. So the whole point is just come to checkup and get your kids checked by a practitioner.
And that brings me to my next question. Are all myopia same or there are different types of myopia in eyes?
Yes, there are
There are?
different types of myopias. Yeah, that's a very interesting question. I feel a lot of knowledge has to go into this field. A lot of these International Myopia Institute papers, the first paragraph they say that we have to enroll only kids who have longer eyeball. So there are kids who have steeper corneas. Earlier I spoke about flatter corneas. They are at more risk. And children who have steeper corneas are at risk of having something known as keratoconus. But a lot of them do not progress to keratoconus. I have kids who have 48 cornea, 48 diopters cornea. Their actual lenses are smaller, shorter, or normal for that age. And these are known as refractive myopias. So it can arise from cornea or the lens inside. So they don't need aggressive treatment. You have to identify who are the kids who have longer eyeball. Shorter eyeballs and normal eyeball lens don't need. So these type of myopias are known as refractive, and what we want to treat is axial myopia.
So axial myopia requires these special interventions
Yes.
that you were saying,
Yes.
and not the ones with the. So every myopic kid will not have to have the intervention.
Yes.
It depends on the practitioner's evaluation and
Correct.
how is the type of myopia in the kid's eyes.
What is the type?
the
These
type.
children who have refractive myopias need to be monitored so that we know we don't miss keratoconus, but they don't need aggressive treatment. I have stopped treatment for kids who have refractive myopias. They are doing well. Their eyeball is growing normally, and let it grow. Why should we do something for a natural growth?
So eyeballs should grow naturally.
Naturally, yes.
Till how long do they grow naturally? Like what can we expect as a parent? Till what years is my daughter's eyeball going to increase?
I would say 20.
Okay.
20 is a average age where it generally stops, but there are a lot of young people now who are into a lot of computers. So there is a term known as adult onset myopia. So till the age of 16 to 18, they may not have myopia at all. And at the age of 18, they start developing myopia. So that can go up to the age of 24. So I generally continue treatment for myopia till 20-25 years, till that age.
So that brings me to my next question to you, which is like very interesting to know that if a kid comes to you at, let's say, 6 years, and you see that the kid has axial myopia, right? So you need to put the kid onto a treatment.
Correct.
How long will this treatment last? Till the kid turns 24, or how do you decide when to stop the treatment?
So there is no stopping the treatment. If he or she has axial myopia, it is only going to increase. So the kid is going to be one of the interventions. So now for myopia, there are drops, there are glasses, there are contact lenses. So one of these things have to be continued till the age of 20 at least.
So you said there are glasses, there are drops, and then there are contact lenses.
Yes.
So my question is, how do you choose which one to give?
Yeah. So yeah, if so at the first time when I see the kid, the younger the kid, the more the aggressive I have to be. So if the kid at the age of 6 has say -3, this kid is going to grow faster. This kid is going to progress faster. So generally my intervention is to start off with glasses and drops together. So I continue this at least till the age of 12, because till then it grows faster. And then based on how child is doing, I slowly taper off the drops and continue glasses. A lot of parents are getting to understand contact lenses. I think so India needs a little more time to get into this, but a lot of parents are open to contact lenses now. There are orthokeratology lenses which can be worn at night and slept, and the morning times the kid does not have to wear any glass or contact lenses to see clearly. So slowly we'll also come to that as people start knowing about it.
So you said there are specs, there are drops, and then there are contact lenses,
Yes,
right?
yes.
So how safe are specs? Are there any side effects of these glasses?
So about all these treatments, specs are the most accepted treatment because the kid does not need to do anything extra. The kid would already be wearing a glass, which is a normal glass. In the normal glass, the kid can see, but it does not control myopia. And myopia control glasses are just the same way how a normal glass looks. So the parent is not doing anything like putting drops every night. So many times they miss the drops. The child is not in front of them. The child is studying, he falls asleep. So there is nothing extra that the parent needs to do or the child needs to do. And they are very, very safe. They do not alter anything in your eye.
So as a parent, I am also worried about drops, to be very honest.
Yes.
So how safe are the drops?
Drops are very safe. Only thing is with drops, some kids can develop allergy. Only those are the kids who needs to stop the drop. But drops are equally safe as glasses, but they are not as effective as glass. The efficacy that we get with the drops is not as much as with the spectacles.
And how safe are contact lenses?
Yeah, so if a daily wear contact lens, like daily disposable, then if I prescribe daily, everyday disposable contact lens, out of 5,000 kids in 1 year can get an eye infection, which is bacterial keratitis. And if it's say a monthly disposable contact lens, so out of 1,500 kids wearing it for a year, one will get a bacterial keratitis. Not much. It's safe, pretty safe.
It's safe.
Yeah.
That's good. So we can either have the drops, we can either have the specs, or we can have the contact lenses.
Contact lens daytime or nighttime.
Or nighttime.
Yeah.
So you said something about orthokeratology contact lenses, right? Can you please elaborate what are those and how do they work in the eyes?
Yeah. So I'll make it very simple. You and I sitting on a chair. We are sitting and the chair goes down. So this is how the lens sits on your eye. It flattens your cornea. So either it is steeper cornea. So when you flatten it, the eye power also goes down. So during the day, the number tends to stay stable. Like they'll come close to 0. The main aim is to see unaided. Like the child may have 0.5, 0.75, but it's still okay for the child. So it flattens the cornea and that's how the child sees. So child is free from glasses or contact lenses during the day. So this is important for kids who are into sports. So say somebody swimmer, somebody is cricketer, footballer, they cannot wear contact lenses, they cannot wear glasses. putting drops is again difficult. So these work very well for those children, and it is for everyone, not that only these children should wear, but especially for these children it does very well. And the kid has to wear it at night again. You cannot stop it in between.
So they wear it, they go to sleep. So they're not doing anything.
The last thing that they do is wear the glasses.
Wear the lenses and go to sleep.
Sleep, yes.
Oh, that's good.
Yeah.
And in the morning they don't require anything.
Yeah, the first thing they do is remove the lenses.
Remove the lenses.
Yes.
So is it also available for grown-ups?
Yes,
Like
it is
grown-up can wear
available.
this as
Yes,
well?
yes, it is available. But for them, na, myopia control is not in that. Yeah. So say I have like say -4, I can wear it to be free of glasses during the day. But for me, it's not going to help for controlling myopia because I have already achieved that, finished that age.
So for kids, it's more of a myopia management. For grown-ups,
Both.
it's more of a vision correction.
For kids, it's both
Myopia management and vision.
correction. So it's dual benefit.
And for grown-up, it's
only
the vision
for
correction. That's
yeah,
good.
yeah.
So you said we can give glasses, we can give contact lenses, and we can give drops.
Yes.
Okay. How do we measure whether they're working or not, or the efficacy of these treatments that you give to the patients?
Yeah.
How do you measure it?
So I have a proprietary software where once I do all these checkups, where I measure the eyeball length, the topography, that is the curvature of the cornea, along with the number that the child has. We put all this data into that, and it has a lot of data as to at that age what the kid's eye should normally grow. Like say at the age of 12, the normal growth of the eye would be 0.1 or 0.15 millimeters in 6 months. If the child is already on myopia treatment and at least half of it we are controlling, say it was supposed to grow only by 0.1 millimeter and we have stopped it by 0.05 millimeter, that means it's working well. But if it is more than that, if the growth of the eyeball is more than what is expected in the last 6 months for that child, that means it may not be working well. And sometimes, or so many times I would say, that it is not that the treatment is not working well, the child is not able to follow a lot of things. So when we counsel the parents and child, we say that we are doing only what is available from our side, what the science is able to do for you, but there is no replacement for lifestyle. If the child is not going out, if the child is continuously on near things, and it's not only mobile, it is even drawing, painting, a lot of near work, storybooks. A lot of children love to be indoors. They just want that time to read storybooks. And those are the kids who will generally not do well. So when we ask the parents continuously, many times we come to know that the child is not able to follow what we have said. So we have to give a lot of time after finishing everything in the clinic. That lifestyle still remains the most important factor for myopia control.
So lifestyle is important. And as you said, parents, what we have seen in our childhood is that if the parents has glasses, the kid might have a glasses as well. Because when we were kids, a parent who is a doctor, the kid will also become a doctor. And both of them will have glasses.
Correct.
Is it true? Like, does it come through parents? Is it genetics? How is it?
Yeah. So we still haven't found a very particular gene which is responsible for myopia. But what I have seen, if the parent is myopic, their children are generally going to follow the same kind of lifestyle that their parents followed. So that's why myopia becomes more in that family. So say a parent was more into reading, the mother and father both were into reading, they will teach their kids also the same thing, that you have to study, you have to read storybooks. Or if the mother was a painter, she will teach that as a hobby to the child. So this is more important than the genetic part. Like we still haven't found, so we can't blame a gene still for myopia, but what the parents have done generally continues in children. So that's a family protocol, I would say, what they follow, and that is probably more important for myopia progression in these children.
So to go back to my question,
Yes.
if the doctor's son was not a doctor, he or she would have kept the glasses away. Might happen because if the behavior was not the same as the parent,
Yes.
then the kid might not have got a glasses.
Yes.
Right?
Yeah. So it's a behavior pattern in the family. Yeah. Yes.
And might not be genetics and can be changed. So if
Can
I have
be
a
changed.
minus number,
Yes.
if I have the right kind of a environment and the behavior of my kid under control,
Correct.
he or she might not get
Less
glasses.
likely to
Less
develop
likely to get
myopia.
glasses.
Yeah. Though if both parents are myopic, the child has 6 times higher chance of becoming myopic. But it's not that he will become myopic. So if the child is exposed to a lot of good lifestyle, like especially outdoors, being outdoors earlier in life and less of near work, I feel the child is less likely to develop. Yeah. I also feel the government should actually stop taking kids early into schools. It should be minimum 7 years, nothing below it. Just play outside. Yes.
So play outside at least 14 hours in a week.
Yes.
And don't do digital devices more than 2 hours in a day.
Yes.
And farther, bigger is better.
Yes.
Got
Yes.
that.
Yes.
Got that. Now, that other question that I would love to ask you is that when we went into a clinic, we saw a plethora of instruments inside, right?
Yes.
Which you normally don't see in a normal practice.
Correct.
So, do you request so many of instruments to check a kid's eyes? Or can you tell us a bit more about the instruments that you have?
Yeah. So, see, I want all my fellow doctors to practice myopia. So, there is nothing like you cannot practice myopia if you don't have this instrument. Every doctor with basic minimal knowledge of myopia, binocular vision function can start practice. Only I would say doctors who are interested to grow their clinic into a very personalized myopia clinic or a very focused myopia clinic need all these instruments. But there is no restriction. Any doctor who is into general practice can practice.
So, you said any doctor who is in general practice can do myopia.
Yes.
But you have not seen many doctors take up myopia as
Yes.
of now.
Yes.
What do you think is the reason for that?
I think so, a little bit of motivation, a little bit of knowledge, and that pattern of believing that the parents may not listen. So it is about how we can convince them with our knowledge that this is important. Like so many times, it's time consuming, and until you learn how to talk and how to take this in a simple way, that initial phase takes a little longer time. And once the doctor crosses that initial phase of talking minimum and taking less chair time, I think so after that it becomes easier.
That's very insightful.
Yeah.
You said something about binocular vision function. We
Yes,
also saw a board about that
Yes.
outside your clinic.
Yes.
What is this binocular vision function?
Yeah. So again, to make it simple, all of us have 2 eyes. Most of us have 2 eyes, and they have 2 functions. One is aiming, and one is focusing. It's like a binocular. You have a binocular. First, you look at a star, and you try to aim at that star first, and then you want to get it into a fine focus. So if I'm looking at your nose, my first thing is to look at your nose and then focus it finely. So binocular vision is about all these muscles doing that for you. If there is any imbalance in these muscles, even then myopia can progress faster. So as a doctor, a little bit about binocular vision function you should know, a doctor should know to practice myopia.
So if I have a binocular vision problem or my child has a binocular vision problem, they might not be able to aim or focus correctly.
Yes.
So will that affect their studies and games as well?
100%, yes. There is a study where ADHD is more common in children having accommodation insufficiency. So accommodation is the ability to focus on near things. Myopic children can do that, but not all. Those who have accommodation insufficiency, especially we measure something as accommodation lag in children. That's the minimum thing that I do in my practice, a retinoscopy, accommodation lag. And if the kid has that, then he is more likely to progress into myopia.
So if they can't aim or they can't focus, there will be a attention deficit,
Yes.
hyperactive disorder kind of a thing.
Yes.
You said something about retinoscopy. What's that?
So retinoscopy is the most important instrument in my clinic, where it's just a simple instrument where I flash a little light and I come to know what approximately the child can have a power.
So is it like complementary to the digitalized testing that we see everywhere now?
It is probably better than that if done properly. Yes,
okay.
if done properly. Yes.
That's interesting. And how do you think we can build more awareness about myopia and myopia management over a period of time? What do you think we should do?
So I think so practitioners in India have a lot of scope for this. We have a longer waiting time. Generally, all the practitioners are busy practice. So when the parent is waiting, even if they don't have children, or someone who is a little elderly, say grandparents come, you have to build a culture in your clinic where they cannot go out after finishing the consultation without knowing something about myopia. So everywhere, wherever they sit, wherever they are seen, or whatever the receptionist is doing, should somewhere be seen, like the myopia thing should be seen. So we have a lot of posters, we have 2 dedicated TVs playing about myopia, so we have a lot of waiting time, so that the children or the parents can see what is myopia, why it progresses, and why should you get your kids checked for it. So it's a culture that a practitioner can develop in his or her clinic for awareness. This is what the practitioner can do, and I feel a lot of things the government also can do, the schools can do, like a compulsory eye checkup before going to the next grade. And I think there should be some TV advertisements where that is the most easiest and most impactful thing. TV, Facebook, Instagram, WhatsApp. Yeah.
So you are saying that the more information we give out there, the better it is,
Yes.
and the awareness is going to increase as
Yes.
well.
Yes.
That's very insightful. But before I let you go back to your busy practice,
Yes. Yes.
the final question that I would love to ask you is, what will be your take-home message to the people who are listening to us today?
So I would say, let the child be child. So that's why I said we should probably not send our children till the age of 7, because it's very, very important to play outside. That is what our childhood has been. Like now you see, we don't have playgrounds outside. It's a busy road. Children are not playing outside on the roads. It's not their fault as well. So what I would tell my parents or my patients is that let the child be a child. Don't force them too much into picking up a hobby too early in life and be restricted to home, or read too much or do a lot of painting, drawing. Let them do. I am not against any of these, but let the child be child. Let them
that's a
do
very
what
important
they
message.
have done in their childhood. Yeah.
That's very insightful. That brought me to probably one of the last question that I would love to ask you
Yes.
is, you said that specs are good, they slow down the progression of myopia, but how do I choose a frame for my kid basically? They all like colorful frames, that's for
Yes,
sure.
yes, yes.
But is there a special way of choosing a frame for my kid, or how is it?
Yes. So we have opticians who are trained for that. I make sure that the child understands before he goes to the optician. I tell the child that you pick up a frame that you like, but let us take the final call. So the frame has to sit properly on the nose. There are a lot of things related to the frame also. The practice doesn't end when the kid goes out of my clinic. It ends after we dispense the frame. So there is something known as back vertex distance, there is something known as pantoscopic tilt. All this has to be correct. The child has to have a frame which is slightly in the center, like the eyeball has to come slightly in the center, because these all myopic glasses have ring pattern in them. The center portion 7 to 9 mm is clear, and the rest of the glass has these rings which should come right in the center of the pupil. So it is better. It's not that the child will not do well if it is slightly decentered, but we wish that it comes in the center.
So there is a science behind choosing the frames as
Frame
well.
as well, yes.
So you have to trust your practitioner, talk
And
to
the
your
optician,
optician,
yes.
and then choose the right frame
Yes.
for the kid
Yes.
based on their power and their facial structure.
Yes, yes.
That's great. With that, allow me to thank you a lot from
Thank
the
you
bottom
so
of my
much.
heart for taking out time from your very, very busy practice
Thank you so
for
much.
this podcast. Thank
Thanks
you,
for
thank you,
having
Dr.
me.
Rahul. Thanks
Thank
a lot.
you.